بسم الله الرحمن الرحيم. Extrahepatic biliary atresia. As we know, jaundice is the other discoloration of the skin and sclera, and clinically would be appear in the sclera of the patient when the level of the serum bilirubin is above 2.5 milligram per deciliter. Biliary atresia, extrahepatic biliary atresia, is one of the causes of the jaundice in the neonate, which is of obstructive type. It accounts for 1 per 12,000 live birth. يعني من كل 12,000 طفل يولد وعنده extra hepatic biliary atresia. Atresia mean أثري، يعني القنوات الصفراوية تكون أثرية أو ضامرة. And it affects both male and female equally. The extrahepatic bile ducts are progressively destroyed by an inflammatory process which starts around the time of the birth. The etiology is unclear, and the intrahepatic changes also occur and eventually result in biliary cirrhosis, portal hypertension, ascites, and all the features of the liver cirrhosis will appear in the patient with esophageal varices, and the patient also may present with hematemesis and medina. And if you untreat this patient, this neonate, it will result in liver failure and death before the age of 3. And the type of the atresia can be classified into 3 types. Either atresia restricted to the common bile duct, second type atresia of the common hepatic duct, and the third type atresia of the right and left hepatic duct. As you see here, this is the gallbladder, this is the cystic duct, and this is the common hepatic duct, right hepatic duct and left hepatic duct. These ducts are not obliterated. These ducts are patent. So there is no atresia here, and the atresia here in the common bile duct. As you see here, the common bile duct is very narrow duct. تقريبا القناة الصفراء متحول إلى حبل أو خيط فقط. So it is not patent and not allow for the bile to excrete from the liver to the duodenum. So this is the type 1. The type 2 here, we can see the common bile duct is atretic, and the common hepatic duct also atretic. And this is the third type, where the common bile duct atretic, the cystic duct also atretic, common hepatic duct atretic, right and left hepatic duct atretic. The first one we call this type of the atresia, which involves just the common bile duct, and the common hepatic duct is patent. We call this type of the biliary atresia, this is the surgically correctable biliary atresia. يعني الاتresia that involve the common hepatic duct and not involve the atresia that involve the common bile duct only, not involve the common hepatic duct. And there is part of the biliary tree outside the liver is patent. This type is surgically correctable type of the extrahepatic biliary atresia. We can do a bypass for the obliterated part of the biliary tree in this type of the extrahepatic biliary atresia, type 1. The clinical feature. About 1/3 of the patients are jaundice at birth. As we know, we have several causes of the jaundice at the time of the birth. One of them is the extrahepatic biliary atresia. Not all the cases with the biliary atresia will present with jaundice at the time of the birth. Only 1/3 of the patients are jaundice at birth. Jaundice will appear by the end of the first week in all patients with the extrahepatic biliary tree. يعني إذا ما طلع عنده jaundice باليوم الأول نهاية الأسبوع he will develop the jaundice and become deepen progressively. Liver function test show an obstructive pattern. يعني معناه liver function test we can see in the liver function test the total serum bilirubin direct type will be increased. And the direct type of the total serum bilirubin mean the an increase in the level of in the serum level of the conjugated bilirubin. The conjugated bilirubin is increased, mean the cause of the jaundice is obstructive type. Also, the alkaline phosphatase increase in the obstructive type of jaundice. Here we have the extrahepatic biliary tree, in which the alkaline phosphatase will be increased. طبعا because the bile will not reach to the meconium, to the intestine, the meconium to start with may be bile stained. Later on, there is no bile stained meconium, and the meconium and the stool will be pale. طبعا in the adult, when we have jaundice, obstructive jaundice in the adult, the stool will be gray color stool. يعني شكل الستول راح يكون مثل الطين. هنا بالنسبة للنيونيت the color of the stool would be pale. Normally the color of the stool is golden yellow after the end of the first week of life. The urine will become dark, or we call it tea color urine. Prolonged steatorrhea, because there is no bile in the intestine, and the bile important for the absorption of the fat, so the fat will be within the stool, and this leads to steatorrhea, and this leads to deficiency of the vitamin D, which lead to formation of the what's called the biliary rickets. Biliary rickets, which is an osteomalacia in the neonate. We call it the biliary ricket because the cause of the ricket is deficiency of the bile in the intestine, which is important for the absorption of the fat-soluble vitamin, and because vitamin D is the fat-soluble vitamin, there will be deficiency of the vitamin D, which is responsible for the biliary rickets. And due to deposition of the bile salt in the skin, this leads to pruritus, which is severe, and clubbing of the finger and skin xanthomas, and this is related to an increase in the serum cholesterol level. What are the differential diagnoses of the extrahepatic biliary atresia? And this may be any form of jaundice in the neonate, which lead to what's called the cholestatic jaundice. And we have several causes for this jaundice, which may be important differential diagnosis for the extrahepatic biliary atresia. One of them, first, the alpha antitrypsin deficiency, which is one of the inherited disease in the neonate, in which the problem is with the lung and the liver of the baby or the neonate. There will be destructive lung disease and emphysema in the neonate with the liver damage and liver cirrhosis. And we call this the alpha antitrypsin deficiency. The second one is the cholestasis associated with intravenous feeding. Any problem that prevent the baby to have oral feeding, like tracheoesophageal fistula or any other cause, bowel resection, this lead to what's called the cholestatic jaundice, because there is no food in the intestine, and this food, and particularly the fat in the duodenum, lead to secretion of the bile. And because they have no fat in the intestine, there will be no release of the enzyme called the cholecystokinin pancreozyme, which is responsible for the excretion of the bile and relaxation of the sphincter of Oddi. So the patient will develop cholestasis, which look like the extrahepatic biliary atresia. The other differential diagnosis is the choledochal cyst. This will be discussed later on, which is one of the congenital anomaly of the biliary tree and lead to jaundice also. The other differential diagnosis is the inspissated bile syndrome. The bile will be thick and will cause obstruction to the biliary tree and the common bile duct, and the patient would present with cholestatic jaundice, which look like the extrahepatic biliary atresia. And the fifth differential diagnosis is the neonatal hepatitis, which is the most difficult one to differentiate from the extrahepatic biliary atresia, because both extrahepatic biliary atresia and neonatal hepatitis are associated with giant cell transformation of the hepatocyte, and the only way to differentiate both is by taking a liver biopsy. Treatment of the extrahepatic biliary atresia. Patent segment of the proximal bile duct are found only in 10% of type 1 biliary atresia. The type 1 biliary atresia, we call it the surgically correctable biliary atresia, in which we will do anastomosis with the jejunum and a direct ROX NY hepatojejunostomy. We bring loop of the jejunum and suture it with the accessible part of the biliary tree, and this will achieve bypass for the obstruction. يعني كأنما نسوي شطل للبلياري tree. مكان الانسداد will be overcome by the direct anastomosis of the jejunum with the extrahepatic part of the biliary tree, which is not obliterated. Or we can do for them, for those with the type 2 and type 3, the only way to treat such patient is by doing liver transplant for them. Liver transplantation is the best treatment for those patients with surgically non-correctable extrahepatic biliary atresia, and there would be improvement in about 70 to 80% alive to 5 years following transplant. يعني الأطفال راح يعيشون 70% إلى 80% من الأطفال راح يعيشون لعمر ال5 سنوات after liver transplant. The other disease of the biliary tree, congenital disease of the biliary tree, is the choledochal cyst, which is a cystic disease of the biliary system. Also rare, and the choledochal cysts are congenital dilatation of the intrahepatic and extrahepatic biliary system. The pathogenesis is unclear. مثل extrahepatic biliary tree, also the pathogenesis of the choledochal cyst is not clear. Patient may present at any age with jaundice, fever, abdominal pain, and right upper quadrant mass. Jaundice, fever, also rigor, and these are the feature of cholangitis. Cholangitis, which is inflammation of the biliary radicals, present with fever, rigor, and abdominal pain. And one of the clinical feature of the choledochal cyst is the cholangitis. 60% of the cases are diagnosed before the age of 10 years. Pancreatitis is not an infrequent presentation in adults. And choledochal cyst may lead to pancreatitis. One of the causes of the pancreatitis is the choledochal cyst. Patients with choledochal cysts have an increased risk of developing cholangiocarcinoma. That's why any choledochal cyst should be excised. لأنه choledochal cyst is a precursor for cholangiocarcinoma. Predisposing factor for cholangiocarcinoma in the children is the choledochal cyst. So any choledochal cyst should be excised. The diagnosis is by ultrasound or by ultrasound or CT or MRI or MRCP. Radical resection of the cyst is the treatment of choice, with reconstruction of the biliary tree using Rho and Y loop of jejunum. And these are the type of the choledochal cyst. As you see, type 1A and B. This is diffuse cystic type, or we call it fusiform or saccular type here. Fusiform and saccular type 1 and B. Or type B we have here the what's called the diverticula of the common bile duct. Here we have a diverticula of the common bile duct. While here in the type 3 we have the diverticula within the pancreas, within the head of the pancreas. While the type 5 we have extension, type 4 extension within the liver. Yani the saccular dilatation of the biliary tree are within the liver tissue. Or in type 5 we have only intrahepatic dilatation due to choledochal cyst. These are the types of the choledochal cyst. The commonest type is the type 1A and B, saccular or fusiform type of the choledochal cyst. Now we'll go to a very common disease. That's the gallstone, cholelithiasis. Gallstone are the most common biliary pathology. It is estimated that gallstone affect 10 to 15% of the population in the Western societies. طبعا هذا أيضا يشمل مناطقنا احنا الدول النامية مثل العراق. The percentage of the patients with gallstone increased in the last decade. يعني العشر سنوات الأخيرة وحتى العشرين سنة الأخيرة the risk of the gallstone is increase. واحنا نعرفها هاي من خلال عدد العمليات اللي تجرى لرفع المرارة في المستشفيات العراقية. يعني في مستشفانا مستشفى الديوانية التعليمي بالأسبوع الواحد لا يقل عن 15 إلى 20 عملية رفع مرارة تجرى باستخدام الناظور أو بطريقة الأوبن. بمعنى the risk and the percentage of the gallstone is increasing even in our country. The cause of the gallstone can be divided according to theories into three. The pathophysiology of the gallstone formation can be divided into metabolic theory. Before that, we can classify the gallstone into three types: either cholesterol type, pigmented type, mixed stone. The cholesterol type, we call it the gallstone solitaire. That means there is usually single, large, smooth surface gallstone. So we call it the cholesterol. We call the cholesterol type of the gallstone solitaire. Pigmented type usually brown and black, And we have the mixed type of the stone. Those patients with hemolytic jaundice, they develop pigmented type of the stone. The pathophysiology of the stone formation, either the metabolic theory, and the metabolic theory, for cholesterol to remain in the solution, we need the bile acid. احنا بحاجة للبايل acid حتى يصير absorption للكوليسترول, because the bile acid will change the fat molecule from a molecule that not be absorbed because it is hydrophilic, because it is not hydrophilic, because it's hydrophobic. يعني molecule that not be absorbed in the water. The bile acid and phospholipid and bile acid with the cholesterol will form what's called the Micelle. Micelle is fat molecule with bile acid. The micelle is a fiber, it is hydrophilic particle. It is hydrophilic particle or molecule that can be absorbed, and it's formed by the attachment of the bile acid to the fat molecule. Any cause that increase in the level of the cholesterol or decrease in the bile acid, this lead to a bile which is liable to form the gallstone. We call this bile supersaturated bile, or we call the lithogenic bile, and lead to formation of the gallstone. So a lithogenic bile or a supersaturated bile, a bile in which the level of the cholesterol either high or the level of the bile acid is low. Either high cholesterol or a low bile acid. This is supersaturated bile or lithogenic bile, which is liable to form the gallstone. What are the causes of the lithogenic bile? A lithogenic bile can be caused by high caloric diet, excess intake of the carbohydrate. This leads to formation of the supersaturated bile or lithogenic bile. Obesity. And the obesity, we have higher level of the cholesterol and triglyceride, and this means the bile in those patients is lithogenic bile or supersaturated bile. Contraceptive pills and cholestyramine, or those lead to formation of the supersaturated or lithogenic bile. Resection of the terminal ileum, this will be a cause for the interruption of the enterohepatic circulation of the bile. So this leads to decrease in the bile acid, and decrease in the bile acid lead to formation of the supersaturated or lithogenic bile. So the cause of the lithogenic bile are high caloric diet, obesity, contraceptive pill, and cholestyramine, drug or resection of the terminal ileum. The second theory behind the formation of the gallstone, the nidus of the infection, which lead to aggregation of the nucleated cholesterol crystal and stone formation. And the third theory, stages of the bile lead to stone formation, مثل عمليات الفيجوتومي اللي كانت نسويها قبل بقرحة ال 12 in the peptic ulcer, duodenal or gastric ulcer. We perform vagotomy, and this vagotomy lead to decrease the motility of the stomach and the biliary tree, and lead to stages of the bile and formation of the gallstone. Or those patients with total parenteral nutrition, يعني مرضى ياخذون they take their diet by intravenous way for any cause that prevent them from taking the diet orally or intrally. مثل those patients with bowel resection, bowel anastomosis, bile leak, or intestinal fistula, we give to those patients the diet by intravenous way, and those patients develop, because they have no no fat in the duodenum, and there is no secretion of the bile, so they develop the cholestatic jaundice and develop gallstone later on. Pigmented stones associated with hemolytic anemia مثل spherocytosis, sickle cell anemia, thalassemia. This leads to destruction of the RBC and excess release of the indirect bilirubin or unconjugated bilirubin, and this leads to formation of the gallstone, which are a pigmented stone. The fifth theory behind the formation of the gallstone, stone formation related to the deconjugation of the bilirubin by D-glucuronide by bacterial glucuronidase that release glucuronidase enzyme and insoluble unconjugated bilirubin precipitate and lead to formation of the gallstone. The sixth cause of the gallstone formation is brown pigmented stone associated with the presence of the foreign body within the bile duct, such as parasite or stent. Stent هو عبارة عن عبار نخليه بالcommon bile duct to overcome obstruction of the common bile duct, which could be due to tumor or due to stenosis of the common bile duct. And this stent would be would form a nidus for the formation of the stone in the gallbladder or in the common bile duct, or parasite like parasitic infestation due to Ascaris lumbricoid or Coronarca sinensis. These parasite inhibitant for the biliary tree and cause stages of the bile and formation of the gallstone. These are the type of the stone here. As you see, the stone here faceted, كلش clear, multiple gallstone. Also another pigmented stone here. Here we can see the nidus of the stone due to infection here, start infection here, lead to formation of the stone over a nidus of infection. This is the gallbladder opened and the stones within the gallbladder. The clinical feature of patients with gallstone. We have what's called the 5F. A female, fertile, 40, fatty, and flatulence dyspepsia. 5F, female more than male, fertile يعني multipara, يعني woman with more than one child, 40 years or 50 years of age, fatty, obese, and the patient have flatulence dyspepsia. These are the 5F of the gallstone presentation. The patient may be asymptomatic, and on this type of gallstone we call it silent gallstone. A silent gallstone without symptoms and sign. We discovered that type of gallstone accidentally when we are performing an ultrasound for the abdomen of the patient for any other cause. Or the patient present with chronic cholestasis. In the chronic cholestatis, we have pain in the epigastric or right hypochondrial region of the abdomen. This pain radiating to the back and to the interscapular region and to the right shoulder, aggravated by fatty meal, associated with nausea and vomiting, and belching and dyspepsia, and particularly the flatulence dyspepsia. On examination of this patient, there will be tenderness in the epigastric and right hypochondrium. or the patient presents with acute cholecystitis. Acute cholecystitis, the other type of presentation of patient with gallstone. And acute cholecystitis, we have pain which will be more severe than the pain in the chronic cholecystitis, and pain lasting more than 12 hours, and the abdomen will be tender with muscle guarding and rigidity with a positive Murphy sign. Murphy sign means that you put your left hand on the right costal margin and the lower costal margin of the right side of the patient, and the thumb, your thumb will be in the subcostal space on the fundus of the gallbladder, and we ask the patient to take a deep breath. At the zenith of the inspiration, the patient would catch his breath because the fundus of the inflamed gallbladder will touch the parietal peritoneum and develop pain. This is a positive Murphy sign, which is usually positive in the acute cholecystitis. Or a Bose sign, this means hyperesthesia between 9 and 11 rep posteriorly in the back and the right side of the patient. This hyperesthesia can be described by the patient as that the patient cannot withstand even the weight of the cloth. يعني المريض يحس حتى الملابس مالته من الطخ منطقة area between the 9 and 11 rep posteriorly, he will develop pain from even touch of the cloth. This is called the Bose sign. And if we did for the patient complete blood picture, there will be leukocytosis with elevated also liver enzyme and liver function test. What are the differential diagnoses of gallstone? Common differential diagnosis: acute appendicitis, perforated peptic ulcer, acute pancreatitis. A rare cause of the differential diagnosis of the gallstone is the acute pyelonephritis, myocardial infarction, and pneumonia, a right lower pneumonia. What are the complications of the gallstone? Either biliary colic, which is severe pain, severe colicky intermittent pain, and the right hypochondrium radiated to the back and to the shoulder. And the other complication is the acute cholecystitis. The third complication, chronic cholecystitis. And the fourth complication is the empyema of the gallbladder. If we have a stone impacted in the neck of the gallbladder at the cystic duct, it leads to formation of a pouch called the Hartmann pouch. Hartmann pouch is a pathological type of pouch. It's not an anatomical pouch, and this is due to impaction of stone in the neck of the gallbladder. At first, the bile would cause distension of the gallbladder, and the bile will be absorbed. When the bile absorbed, the only mucus will retain in the gallbladder. This leads to formation of the mucosine. And when the mucosine invaded by the microorganism and lead to formation of pus within the gallbladder, this is called the empyema of the gallbladder. Those patients with empyema of the gallbladder will present to you with tenderness, pain and tenderness in the right hypochondrium with a palpable tender mass with fever and rigor. The other complication is the mucosine. In the mucosine, you have just palpable gallbladder in the right hypochondrium with the previous history of gallstone. The other complication is the perforation. Perforation of the gallbladder is rare due to gallstone. Only when we have infection with a special type of microorganism like the Clostridia Wiltshire infection with gangrene of the gallbladder, this leads to perforation of the gallbladder. When we have perforation of the gallbladder, there will be biliary peritonitis, later on bacterial peritonitis and septicemia. Biliary obstruction. Stone from the common bile duct, from the gallbladder will be descend to the common bile duct, and to the lower end of the common bile duct lead to obstructive jaundice. Acute cholangitis, where we have pain, fever, or rigor, and jaundice, and this is called the Charcot triad. Charcot triad means fever, rigor, pain, and jaundice. These are complications of the gallstone. Acute pancreatitis. During the passage of the stone from the gallbladder to the common bile duct to the intestine, it would cause obstruction to the pancreatic duct, and this obstruction to the pancreatic duct lead to triggering of the pancreatic enzyme, lead to acute pancreatitis. And the last complication is the intestinal obstruction by the gallstone ileus. A stone from the gallbladder will pass to the duodenum through a abnormal communication between the gallbladder and the duodenum, which is called the cholecystoduodenal fistula. And this stone will be obstructed, will be increased in size due to presence of the fecal concretion around the stone, and become larger and larger, then will be impacted in the narrowest part of the small intestine, which is about 2 feet from the ileocecal junction, and lead to what's called the gallstone ileus or the gallstone colic. These are the complications of the gallstone. Diagnosis of the gallstone by history and physical examination, ultrasound or scan or MRC. Treatment of symptomatic gallstone is surgery. It is safe to observe patients with asymptomatic gallstone, but the indication of cholecystectomy in asymptomatic gallstone are يعني مريضة at gallstone without symptoms and sign. شو وقت راح نسوي لها عملية؟ So we have indication to interfere in those patients with gallstone without symptom and sign. Indication of cholecystectomy in asymptomatic gallstone are in diabetic patient or immunocompromised patient, because more liable or more prone to complication. They are more prone to cholecystitis and acute cholecystitis, even septicemia due to presence of the gallstone. Second, stone more than 2.5 cm in diameter. Large stone lead to irritation of the epithelium of the gallstone and mucosa of the gallbladder. This irritation of the gallbladder mucosa lead to metaplasia and liable to develop malignancy later on. Porcelain gallbladder, which carry risk of malignancy in 25%. This means a calcification of the wall of the gallbladder that can be seen by the plain X-ray of the abdomen. We call it porcelain gallbladder. Liable for malignancy. That's why we should do cholecystectomy even if the patient without symptom and sign of gallstone. Those with congenital hemolytic anemia, when we are doing for them splenectomy at the same time we will go to do cholecystectomy for them even if the patient have no symptom and sign of the gallstone presence. Those patients who are undergoing bariatric surgery for morbid obesity, because those liable to later on develop gallstone, so we'll go to do for them cholecystectomy even if we have cholecystectomy, even if they have stone without any sign and symptom. Conservative treatment of acute cholecystitis. More than 90% of the cases with symptom of acute cholecystitis subside conservatively by non-operative methods, depending on the nothing by mouth, intravenous fluid, and antibiotic. And the antibiotic usually use the third generation cephalosporin, cefazolin, cefuroxime, and gentamicin. And the subsequent management, when the temperature and pulse and the physical signs show that the inflammation is subsiding, oral fluid will be started, and later on we will proceed to do for them cholecystectomy. The timing of surgery in acute cholecystitis remain controversial. يعني شو وقت نسوي العملية in patient with acute cholecystitis. This decision depend on certain schools. One, early cholecystectomy during acute cholecystitis appear to be safe and shortening the total hospital stay, provided that the operation is undertaken within 5 to 7 days of the onset of the attack. The conversion rate in laparoscopic cholecystectomy is higher in acute than elective surgery. طبعا إذا نسوي عملية المريض with acute cholecystitis ممكن يكون the surgery is difficult due to presence of the edema, the acute inflammatory process, adhesion to the bowel. That's why laparoscopic surgery may change to open surgery in those patients in a higher rate. يعني عدد المرضى اللي يتحولوا من lap إلى open in acute cholecystitis more than the chronic cholecystitis. If an early operation is not indicated, one should wait for approximately 6 weeks for the inflammation to subside before operation. إذن the first option we have early cholecystectomy. إذا يعني المريض عنده acute cholecystitis راح نسوي له cholecystectomy within 5 to 7 days. بس هنا نتوقع ال conversion rate from lap to the open is higher. Or we will wait for 6 weeks. ننتظر شهر ونص يلا نسوي العملية هنا. طبعا راح تكون the operation is easier. The conversion rate from lap to open is less. Cholecystectomy. Type of the cholecystectomy. We have either conventional open approach or laparoscopic cholecystectomy. We call it lap chole. مختصر معناته lap chole mean laparoscopic cholecystectomy. How we prepare the patient for surgery? By doing full blood count, renal profile and liver function tests, prothrombin time, chest X-ray, ECG, antibiotic prophylaxis, deep vein thrombosis prophylaxis يعني مثل نعطيهم enoxaparin or other measures to prevent thrombosis. Informed consent ناخذ التوقيع مالت المريض وأهل المريض بإجراء العملية. The golden rule in cholecystectomy, open or lap, is the identification of the calloid triangle. أهم point عند إجراء عملية اللاب كولي or open cholecystectomy إنه we identify the calloid triangle. As we know, the calloid triangle bounded by the cystic duct, كمان hepatic duct and liver. The anomaly of the biliary tree or the vascular anomaly can be seen within the calloid triangle. لاب كولي. طبعا لاب كولي راح اشرح لكم اياه محاضرة منفصلة later on. The patient, few points about the lap chole. The patient will be in supine position with general anesthesia, with anti-Trendelenburg position, with tilt to the left, umbilical pneumoperitoneum, يعني ننفخ البطن بغاز ثاني أكسيد الكربون, to perform a room for surgery, epigastric port, then for surgeon port, mid-clavicular port for the surgery, additional port for the assistant. يعني راح نخلي نسوي 3 أو 4 بورتات, 3 أو 4 opening in the abdominal wall after insufflation of the abdomen with the CO2. Then we identify the triangle of the calloid. Then we proceed to do cholecystectomy by laparoscope. Open cholecystectomy. Indication of the open cholecystectomy. For patients whom laparoscopic approach is not indicated or in whom the conversion from laparoscopic approach is required. يعني either from the start راح نسوي لهم, احنا نقرر نسوي العملية by open method لأنه ما يتحمل العملية by laparoscope. Either the patient have a cardiopulmonary problem that prevent make the general anesthesia risky for the patient, or we are proceeding with the lap chole, laparoscopic approach, then we change it to, we convert to open because they have a problem within the with this patient because of the presence of the adhesion, or because the anatomy is obscured, or the color triangle is not well clear, or we have a vascular or biliary anomaly that prevent the laparoscopic surgery to progress. So start to change to open method. In the open method, we either do a midline or right upper transverse incision or cochlear incision, the subcostal incision, and we approach to the cholecystectomy. اكو عبارة مأثورة بالنسبة للأوبن cholecystectomy. It is the left hand of the assistant that doing the operation or all the work. هذا هاي عبارة مأثورة قالها جراح قديم اسمه مونيهان. شنو معناه؟ معناه انه الايد اليسرى مالت المساعد هي راح تساعدني لإجراء عملية، هي تسوي كل الشغل مالت open cholecystectomy, because without this hand we cannot see the field. بدون ايد المساعد مالتي اليسرى اللي تدفع به الباول away from the gallbladder, I will not proceed to complete the cholecystectomy. هاي الصورة نشوف هنا how a gallstone ileus form. هاي الجولبلادر بها stones. هاي cholecystoduodenal fistula. These stones pass to the duodenum, from the duodenum to the jejunum and to the ileum, and the 2 feet from the ileocecal junction, which is the narrowest part of the small intestine. Here the stone will impact it and lead to what's called the gallstone ileus. And thank you very much.